and we know that ultrasound is a modality of choice. You may add hormonal investigations to that, but probably if you're going to do a Doppler, this probably is not required. I'm sorry for this. So that means that if we really want to assess the endometrium, assess the follicle and the endometrium, what do we need to do? We are usually, if we look at the life cycle of the follicle, we know that the follicles before they become antral till pre-antral, they are all very small, and it's a long life cycle of about 150 days, which we cannot study on ultrasound. But beyond the point, the follicle reaches a secondary antral follicle, stage of a secondary antral follicles, which once upon a time we used to say 2 millimeters is probably now even a little smaller than that. We can easily pick up on ultrasound, and from here till maturity and till ovulation and even the formation of the corpus luteum, we can study the entire cycle on ultrasound. This is called a phase of accelerated follicular growth. And this is what we want to study when we do follicular dynamics or when we say we are doing ovulation monitoring. What are we going to assess on the ultrasound? Of course, the growth rate, the dynamicity and the morphology, which is not related only to the follicle but also to the endometrium. Yes, of course, endometrial assessment is as important as the follicular assessment in cases of intrauterine insemination, IUIs or fresh transfer IVF cycles, both at the same time, but it is also equally important if we are going to do frozen transfer cycles. If we say so, we feel we have done sufficient, but this is also not sufficient. What is missing then? We need to assess the functional maturity of the follicle and endometrium. It's never adequate to just look at the size. That just tells us about anatomy and nothing about the physiological status or the functional status of the follicle and endometrium. That means that let us add Doppler to the 2D assessment of the follicle and the endometrium. Why? Because it is the hormonal changes which are occurring throughout the menstrual cycle, and they are quite fast, especially during the peri-ovulatory phase. And it is these changes which reflect almost instantaneously as vascular changes and later as morphological changes. That means the vascular changes are going to occur before. The Doppler changes are going to reflect the instant status of the hormones, and therefore 2D with Doppler is minimum requirement for a follicular and endometrial tracking. Let us start with the follicular quality and the follicular assessment or assessment of the follicular maturity. If we say so, we need to assess the follicle from the time the dominance is achieved. If I say from the time the dominance is achieved, I know the idea that comes to our mind is 10 millimeters. But then we also say that a dominant follicle has a definite growth rate of 2 to 3 millimeters. Does the growth rate has anything to do at all with the size of the follicle? No, it's actually the FSH dependency or FSH sensitivity which decides the growth rate of the follicle. That means that if I say the follicle is dominant, I should actually mean that the follicle has started developing receptors to FSH. And very interestingly, if I said so, we would think that follicles always have FSH receptors. No, the antral follicles, they do not have FSH receptors. They have to get introduced to FSH to recognize it and develop receptors to that. Before that, during the antral phase, the biochemicals reach the antral follicles by dispersion into the stromal tissue. And this stromal dispersion is only possible if the blood levels of these biochemicals in the stromal vessels are beyond a certain level. That is why we talk about FSH threshold. That means unless the FSH in the stromal vessels reaches a certain level, it will not start getting dispersed into the stromal tissues to reach the antral follicles. If it doesn't reach the antral follicles do not recognize this FSH, and it doesn't open the doors to FSH. When it opens the doors to FSH, that is when the vascularity starts developing surrounding the follicle. That means Doppler is not just important once the follicle becomes 14, 15, 16, 17 millimeters. It is important from the time the dominance is achieved, 10, 12 millimeters. And many times, therefore, when we do baseline scan or the day 5 scan, we might have seen multiple follicles. And when we see this multiple follicles, we generally start believing these are the follicles which are going to grow. Oh my God, there are multiple follicles, and that means that multiple follicles will grow, and therefore we have to convert this cycle to IVF instead of IUI. No, remember, look at these 3 follicles that we saw here. This one larger than the last one, but doesn't have any vessels surrounding. Remember, only those vessels which overlap on the follicular wall are perifollicular vessels. So this follicle doesn't have any perifollicular vessel. This follicle, which is just by the side of it, has a few but very minimal. But if we look at the last follicle, the entire hilar flow practically is being pulled towards that follicle, which means that yes, this is the follicle which is a dominant follicle. That means an indirect message on your baseline scan. If you see follicles which are larger than 10 millimeters but doesn't have any flow, these are not hormonally active, these are not going to come in the way of your stimulation, please disregard them and go ahead with your regular treatment cycles. So yes, it is this flow which tells us that the follicle has grown to dominance, and once it grows to dominance, that is when it pulls on all the flow from the hilum, and this is in the natural cycle naturally, and that is when it automatically restricts the growth of the surrounding follicles. That is the reason why when we talk about human reproductive physiology, it is a single pregnancy which is a normal pregnancy. So yes, that means we know now which are the dominant follicles or how many dominant follicles are there, and what are then we going to do. If we know that there are multiple dominant follicles, do we mean that all these follicles are going to grow to maturity? No, probably, because apart from that dominance, it is important that we would check the growth rate of the follicle and of course morphology. When we say growth rate and the morphology, growth rate I already told you 2 millimeters a day, but morphology, the walls have to be thin and isoechoic to the normal stroma, and the shape should be round or oval, and the contents should be completely anechoic. This tells us, yes, this follicle is the dominant follicle, looks good, growth rate is normal, may grow to maturity. If I say so, we need to measure, if I said a growth rate of 2 to 3 millimeters, how are we going to measure the size of the follicle? Most of us, very similar to what I think Dr. Deepak said, for the testes, it holds true for the follicles too. Follicles can never be measured as two measurements. It's a 3D structure. It has to be measured as 3 orthogonal diameters in 2 orthogonal planes. I have it repeated. 3 longest orthogonal diameters in 2 orthogonal planes, which is required. So whenever you see a follicle, rotate the probe, find out if it elongates, find out the longest section, freeze it on one of the images of the dual frame. Do a 90-degree anti-clockwise rotation, take a transverse section, take the longest diameter perpendicular to the long diameter, and the widest side-to-side diameter parallel to the x-axis, and the mean of these 3 is your mean follicular diameter. Please, for God's sake, don't use just 2 diameters to assess or to document the follicular size. Yes, it is true that if the follicle is completely spherical, you rotate the probe, it still remains the same shape. You can just take 1 diameter. In those cases, prefer to take AP diameter rather than side-to-side diameters, because these 2 walls always appear more clear than the side walls because of the physics of ultrasound. We will discuss that if you ask, if it is a query to you as in the discussion points. Yes, it is true. If I said you have to measure 3 diameters, how can you measure it in multiple follicles? Moreover, whenever you have multiple follicles, these follicles are compressed by each other. Because they're compressed by each other, they do not anymore remain round or oval. And if they're not round or oval, the same equation that you use to calculate the follicular volume from the diameters cannot be used for the irregular structures, because those are for spheres or ellipsoid shapes. That means that it is in these cases you need to use more sophisticated softwares like Sono ABC and 3D. That means if you are going to do an IVF cycle where you have grown multiple follicles, yes, it is good to do use a Sono ABC for a final decision of the size of the follicles. And this is a big advantage because it color codes every follicle. Not only it color codes every follicle, if you look at the result sheet, it gives you X, Y, Z diameter, mean diameter and volume of each and every follicle. Yes, it is true that the volume of between 3 and 7 cc usually correlates with the size of 18 to 24, 12 millimeter is approximately 1 cc and 10 millimeter is close to about 0.6 to 0.7 cc. But we are still not used to taking a decision on the trigger based on the volumes. And as I told you, if the shape was irregular, your longest mean diameter is not going to be the correct diameter for the size of the follicle or the correct estimation of the size of the follicle. It is for this reason that whenever you are using Sono ABC to decide the time of the trigger and you still want to depend on the diameters, you should use what is called the volume derived or a volume released diameter, which is in the first column. How does it, how does it differ from the mean diameter? Say for example, if I am taking a mean diameter, I'll take a longest diameter, I'll take longest diameter perpendicular to the long diameter, and then I will take the longest transverse diameter. But we know that the longest diameter, that means the longest transverse diameter, is not actually the diameter of the entire thing. That means it is an overestimation. Same for the transverse also. I am not taking transverse here, I am taking transverse here. So that means mean diameter is always going to be an overestimation. Instead, if I make a sphere of the same volume, that means instead of a pear I am taking an orange of the same 100 cc. The diameter of that orange is actually going to be the mean diameter. That is what is called the mean, that is what is called the volume release diameter, and that is what is always given in as the first column in Sono ABC. That should be your decision maker. And you can also see here the mean diameter is much more than the volume release diameter. That means if you are going to use a mean diameter, you are going to overestimate the size. Let's go further. We know that the follicle is going to grow at a rate of 2 to 3 millimeters a day. So that means when do you do your first scan? You first scan for your IUI cycles, you are going to do on the last day of the oral ovulation or on the first day of the gonadotrophy, depending on what is the stimulation protocol. If on that day you find that all the follicles are smaller than 10 millimeters or they are not dominant, you can directly call them after 5 days. But if the follicle is already dominant, calculate when you expect the follicle to reach 16, 17, 18 millimeters and accordingly call the patient. But beyond that, you must do Dopplers, and beyond that, you should call the patient every day. What are the things that you're going to see before the maturity? You are going to see a perifollicular halo, which appears about 24 to 36 hours before ovulation. You may see a cumulus. I'm saying you may see a cumulus because it's a very tiny structure, and therefore, unless you have zoomed the image and scrolled across the entire follicle, you may not be able to locate it. Not that it is not present, but you may not be able to locate it. Though it is not mandatory also to see the cumulus, but if you see, that is the surest sign that tells you, yes, this follicle contains a fertilizable oocyte. That means in all your cases of unexplained infertility, it is important that you confirm that the cumulus is present. A very important thing that I want to point out here is, remember many times you may see a tiny crescent-like shadow inside the follicle, and this is many a times termed as a cumulus. This is not a cumulus. Cumulus is a cell mass, it is a solid structure. It only appears as a tiny solid projection. It is not a crescent-like structure, that is just a small follicle by the side of a large follicle. So if you see a cumulus, you are more sure that the follicle contains fertilizable oocyte. It is important for your IUI cycles. It is also important for your poor reserve IVF cycles. Apart from that, you may see separation of the inner layer of the follicle, which is a process just before the cumulus oophoros complex is released inside the follicular fluid, and that is seen about 6 to 10 hours before ovulation. And around the same time, you may also see the breaking up of the granulosa cell layer as a niche-like shadow break in the follicular wall, which is called a rose bush concept, which means that we get certain signs in the follicles which tell us, okay, now the ovulation is going to occur. 24 to 36 hours before, 6 to 10 hours before, and so on. But these signs only tell you ovulation is going to occur. It doesn't tell you anything about the quality of the follicle. The quality of the follicle is only decided by the vascularity, and this vascularity, which started developing with the dominance of the follicle, keeps on increasing in abundance to gradually cover about 2/3 to 3/4 of the follicular circumference. It is exactly about 48 hours before ovulation that the RI of the perifollicular vessels fall, and it falls below 0.5, and it is this which correlates to the final estrogen surge. We know that the final estrogen surge occurs about 48 hours before the ovulation. That means that a fall in the perifollicular RI tells you, yes, the estrogen level has gone down, estrogen surge has started, estrogen surge starts, RI falls. That means, yes, now the follicle is almost functionally mature. It is functionally mature, the estrogen level has started rising, but it has just started rising. When it is close to reach the peak, that is when the LH surge starts, and that point is identified by the rise in PSV, which reaches 10 centimeters per second. So the RI is less than 0.5, PSV reaches 10 centimeters per second. It tells me this is the time the LH surge is going to start. Of course, yes, these parameters are not just for IUI, for your IVF cycles. Also, you must confirm these parameters, because when you confirm these parameters, at least in 3 follicles on both the sides before your IVF cycles, that is when you significantly decrease the chance of empty follicle syndrome. Yes, when we say empty follicle syndrome, it's genuine and it is non-genuine, or it is just functional. So the functional empty follicle syndrome can be prevented if you're checking the blood flows before giving the trigger, because it is this blood flows which tells me that the LH receptors have started developing. And if the LH receptors are developed, there cannot be an empty follicle syndrome, because LH will then lead to meiosis. So yes, we are going to check the RI and the PSV of the follicle to know the estrogen and the LH levels. And why is it important to check the blood flows? Is because the better the blood flows, higher is the chance that the follicle will result into a positive pregnancy, because the quality of the follicle is better, because it is this blood flows which relates to the estrogen level, and indirectly the estrogen level tells us the follicular quality. But very interestingly, at all points, I already told you 3/4 of the circumference. I mean, I didn't tell properly. Yeah. So this blood flow, where the RI is less than 0.5, the PSV is more than 10 centimeters per second. The vascularity should cover at least 2/3 to 3/4 of the follicular circumference, not the entire follicle, because that is a natural process to prevent unnecessary hemorrhage into the peritoneum, from the point which is called the apex of the follicle, from where the follicle is going to, the oocyte is going to be released, oocyte cumulus complex is going to be released. That part is deprived of blood supply to prevent unnecessary hemorrhage and also to facilitate the ruptures. So those are the signs which tell us, yes, this follicle appears good in quality, and therefore it demands a trigger if it is a gonadotrophin cycle. For the natural cycles, you can wait. What is very important is that if you are not seeing these blood flows, that is when there is a chance of hypoxia to the oocyte, and if there is a hypoxia to the oocyte, there is a very high chance of chromosomally abnormal oocytes and embryos to result into. If we say so, and there are multiple references and multiple literature evidences to that, but if we say so, Don't you think we should always take a decision based on the Doppler to decide the time of trigger, at least when we are giving treatment cycles? Because if we do so, we know that we are giving a trigger to a fully oxygenated good oocyte. We can decrease the chances of chromosomal abnormalities, at least in the treatment cycles. Today, when in surrounding the follicles, remember the first thing, the vessels, only the vessels which overlap on the follicular wall are perifollicular vessels. If I am seeing the vessel and if I am seeing the follicular wall separately, these are not perifollicular vessels. Second, your color Doppler and power Doppler, your PRF must be set at 0.3, wall motion filter at low 1 and persistence as high. And for your pulse wave Doppler, the sample volume must always be 2 millimeters and the wall motion filter 30 Hz. So yes, that is about the follicle. Now, decision of the trigger, as we know, it is not just the time of the trigger. We also need to decide what should we give as a trigger, especially when there are multiple follicles. Because that's when we are afraid of two things if we are doing IUI cycles. One, of course, is OHSS, and the second is the multiple pregnancies. If we say OHSS, what is the cause of OHSS, the secretion of VEGF, and what is the source of VEGF? The mature follicles are going to ovulate, they are going to produce cooperative, not a great source of VEGF. The suboptimally mature follicles, 15, 16, 17, 18 millimeters, less blood flow, less LH receptors. Because LH receptors are less, therefore they will not receive the LH surge completely. They will therefore result into luteinized unruptured follicle, again not a great source of VEGF. The medium-sized follicles which share FSH and LH receptors, it is these follicles with the effect of LH, they still keep on growing till the LH level is high. Once after the surge the LH level falls, because the LH level falls, these follicles cannot get luteinized and they don't even grow further. These are the follicles which are the main source of VEGF. Therefore, if you have, so just take the message if you don't want, if you feel that the explanation is difficult, and the message is more medium-sized follicles, higher chance of there being more growing follicles and a higher chance of OHSS. That means if I want to prevent OHSS, I will not give HCG, which has a long surge and more chance of developing growing follicles when I have multiple medium-sized follicles. Simple message. If you have multiple medium-sized follicles, 11 to 14 millimeters, that's when don't give HCG or give a very low dose HCG, because that is when is the risk of OHSS. On the other hand, if you want to prevent multiple pregnancies, again, when you have multiple mature and suboptimally mature follicles, that is when, because of the long HCG surge, because of the long LH surge due to HCG, the suboptimally mature follicles will also reach maturity and may result into multiple pregnancies. So, very clear messages. Prevent OHSS, no HCG when you want to have multiple medium-sized follicles. Prevent multiple pregnancies, when no HCG when you have multiple larger or suboptimally larger follicles. It is important to assess the endometrium. Thickness, morphology and vascularity are the three things that we need to assess. We know that the endometrium is a receptor organ to estrogen and progesterone. As soon as the estrogen level starts rising with the dominance of the follicle, the endometrium starts getting multilayered, gradually increases in thickness, 0.3 to 0.5 millimeters a day, to reach 6, 7, 8 to about 12, 13, sometimes even 15 millimeters, especially in the stimulated cycles. Remember, there is no cutoff for the thickness till about 16, 17 millimeters. In stimulated, especially gonadotrophin cycles, if the morphology is normal, thickness alone cannot tell you endometrium is hyperplastic. There can be an endometrium of 10 millimeters which appears hyperechoic, which shows multiple tiny anechoic areas, which means not a normal morphology. This is a hyperplastic morphology, and even a 10 millimeter endometrium can show hyperplastic morphology and is not good for implantation, whereas even 15, 16, 17 millimeters, nice multi-layered morphology. Any of these three different morphological patterns, just a second. any where is my marker? Yes, any of these three different morphological patterns, yes, it is excellent for implantation, and we are going to come to morphology in a minute. So thickness doesn't tell you anything. It has to be a combination of thickness and the morphology which will tell you. And if I say so, the thickness, if you want to measure correctly, again, it needs to be a zoomed image of the endometrium. When the endometrium is not bad for implantation, all three endometria may be great for implantation, but what is important, not the morphology only, it is the vascularity of the endometrium which is important. We know that the estrogen responds as change in thickness, change in morphology, and also increase in vascularity. But not only that, estrogen is shown on the uterus, its effect is shown on the uterus also as cervical mucus, which you are seeing here, and it is also seen as hyperechogenicity of the cervical glands. That means that if we are assessing the endometrium, we have to assess thickness, morphology, and vascularity, all the three things. Yes, it is true that if I say all the three morphologies are the same, I mean they have the same receptivity, why should I document morphology at all? Is because it reflects the levels of estrogen. Say for example, I have three mature, almost mature follicles, mature looking follicles, 17-18 millimeters. I still have a grade B endometrium. That means only one follicle may be great or all the three may be mediocre. But if with those three follicles I have a grade A endometrium, I know all the three are good. That will help me decide what I want to give as a trigger. Sometimes the follicles are placed far from the probe. Ovary is posterior to the uterus. That is when I cannot evaluate the follicular vascularity. That means I cannot evaluate the follicular quality. It is in these cases that I have to check the endometrium, and if the endometrium shows adequate effect of estrogen, it tells me indirectly follicle is good in quality. Let me come back to what I was saying earlier. We are evaluating the endometrium, thickness, morphology, which may be grade A, B or C, and you need to check the vascularity. You may also see the cervical mucus and the cervical glands. The vascularity of the endometrium, if it is an effect of rising estrogen, keeps on increasing with the increase in estrogen. Only when it reaches the inner layers of the endometrium, we are satisfied. We call this intra-endometrial vascularity or zone 3 and zone 4 vascularity. These vessels supply oxygen to the endometrium to make, not only oxygen, also the nutrients to produce an endometrial morphology which is good for implantation to occur. It is the most strongest prognostic marker not only for implantation, for ongoing pregnancy, and if this vascularity is not seen, not only the chances of implantation are low, but even if the implantation occurs, the chances of abortion are very high because the implanted embryo does not get adequate nutrients. It is this vessels which should be covering at least 5 millimeter square area and should have a low resistance flow, Ri less than 0.5. Let me repeat the follicular and the endometrial parameters both. Follicle at least 16 to 18 millimeters, covering at least 2/3 to 3/4 of the circumference, Ri less than 0.5, PSV more than 10. For the endometrium, at least 6 millimeters. Morphology may be A, B or C, not a problem. But the vascularity should reach the inner layers, have a Ri of less than 0.5, and there should be sufficient area vascularized to support the implanting embryo. But that is also not adequate. You should also confirm that the uterine artery PI is less than 3.2, and all these parameters together tell us yes, the chances of implantation are super, whether it's an IUI cycle or it is a fresh transfer IVF cycle. If you don't get these parameters with your follicular size of 18-19 millimeters, don't get upset. You can wait till the follicular size of 25 millimeters. You may be afraid about rupturing, the follicle rupturing without your intervention. This usually doesn't occur because if the vascularity is not adequate, estrogen level is not adequate. If the estrogen level is not adequate, surge is not going to start. But if at all the follicle still ruptures because the cumulative estrogen level may be high, the chances of implantation are less, the chances of fertilization are less, implantation are less, abortion are high. During this period, when I told you already, beyond 17-18 millimeters, we are going to assess the follicle every day. So during this period, you can ask the patient to have natural intercourse or timed intercourse from time to time, and that will cover that period. But you don't want to do an intervention, because if you do an intervention, the chances of that pregnancy ending up into a successful live birth is much less. So that means looking at the Dopplers is something very, very important, and it is also going to result into your higher pregnancy rates. But sometimes it does happen that you might have not been able to assess the patient every day, and when the patient comes, the follicle may have ruptured, or sometimes you give a trigger and the follicle may rupture earlier. Why does that happen? That happens because the surge might have already started, and that also can be made out on your ultrasound. Yes, I told you that the endometrium is a receptor organ to estrogen and progesterone. So those effects will be seen, the progesterone effect will be seen on the endometrium also, and the effect of the surge will be seen on the follicle also. The parameters that I told you about the follicle and endometrium are till the day of the surge. But what if the surge starts? After the surge starts, what happens? As the surge starts, before that there is an estrogen peak. After the surge starts, estrogen falls. The progesterone starts rising. By the time the estrogen surge comes, progesterone takes about 3 to 4 days to reach a plateau. These effects, rise in LH, will result into rise in PSV in the follicle, which tells you that the surge has started. Not only that, on the other hand, the fall in estrogen and the rise in progesterone will result into decrease in the endometrial thickness, will result into fluffiness of the outer margin of the endometrium. It will result into decreased endometrial vascularity and it will also result into increased uterine artery resistance. I know I am cutting it very short and therefore you may have confusions, but that slide can probably be everything for you. Let me tell you what happens after the surge. After the surge starts, let us just imagine estrogen level is rising, the surge starts, the surge reaches a peak, estrogen falls, progesterone starts just after the estrogen peak, and the progesterone gradually reaches a plateau about 4, 5, 6 days. Therefore, rise in LH, increase in follicular PSV, fall in estrogen, decrease in the endometrial thickness and vascularity, rise in progesterone, compacting effect of the progesterone on the endometrium, which leads to that fluffiness, and increase in the uterine artery resistance. Those are the 4 signs which indicate physiological effects of progesterone and LH on the follicle and the endometrium. If you were seeing that the follicle has increased PSV and the endometrium also has these changes, everything is in line, everything is synchronized, go ahead with your trigger and your planning, IUI or IVF. If at all it is, if at all you see that the follicle has already ruptured and you are seeing these changes in the endometrium, which means the rupture has been very recent, because the changes in the endometrium still show fluffiness. This means that it is a progesterone exposure to physiological levels, and you can go ahead with IUI immediately if it's an IUI cycle. It doesn't happen in IVF because the patient is down regulated. Whereas if you see that it's a premature follicle and this affects on the endometrium, which means it's a premature LH surge, and in those cases you might have to prevent the LH surge. That means without even doing your pre-trigger progesterone 1.5 nanogram, you know what is the effect of progesterone on the endometrium, and you can decide what to do next. That means looking at the Dopplers tells you about the functional status. It tells you about the hormonal status instantaneously, and therefore this is the way to go ahead with better results with your IUI as well as your IVF cycles. Thank you very much.
Thank you, Sonal ma'am, for the wonderful